Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent educational grants from Otsuka America Pharmaceutical Inc. and Lundbeck Inc.
Hi, everyone, and welcome to Putting Post-Traumatic Stress Disorder into Perspective for the Practicing Clinician, a Patient Introduction. I'm John Crystal. I'm a professor and chair of the Department of Psychiatry at Yale University. In this program today, we will discuss the following topics: the epidemiology of PTSD, risk factors for PTSD, including genetics, symptoms and diagnosis of PTSD, onset of symptoms and time to diagnosis, burden of symptoms, and then at the end, we'll have a brief case vignette to kind of bring some of the pieces together. So let's start with epidemiology. As you know, PTSD is a highly common disorder, not only in the United States, but throughout the world. The global lifetime prevalence of PTSD varies in various estimates between about 4 and 10% of the population. 1 year in prevalence rates vary between about 3 and 6%. That makes PTSD one of the most common psychiatric disorders in the United States. Now, many people first heard about PTSD because of the high rates of PTSD in combat veterans. Yet, it may be surprising for you to know that over 80% of the patients in the general population who have PTSD are not connected with the military at all. And a minority of patients who have PTSD are in the smaller group of veterans. In the civilian population, the overall rate of PTSD is 2.6% and 6% for men and women, respectively. Whereas in the military population, the prevalence is higher, as you might expect, 6.7 and 11% respectively. In the general U.S. population, about 13 million adults will experience PTSD during a given year. And 7 to 8% of people will experience PTSD at some point in their lives. So who are these people? The reality is that PTSD can develop at any age, across genders and identities. The incidence of PTSD is about double in women than men. The lifetime prevalence of PTSD is 13% in women and 6% in men, as we talked about just before. Females in the general population experience PTSD for a longer duration than males as well. The typical onset age for PTSD is young and middle adulthood, and the median age of onset is about 23 years. In the United States, PTSD varies by race and ethnicity, with the highest rate of PTSD in the Black population, about 8.7%, the white population and the Hispanic population, about 7%, and the Asian population, about 4%. As you know, PTSD can come from many different kinds of life experiences, and there are some differences in the rate at which people develop PTSD after different kinds of experiences. So, for example, sexual violence results in a 5.6-fold increased risk of developing PTSD. Child abuse, a little bit less. Life-threatening injury or interpersonal violence or combat exposure, in the 3 to 5 fold increase. And traumatic brain injury also increases the risk for PTSD. So, um, the you know, although the risk varies by trauma type, um, you can get PTSD from any of these kinds of experiences where you feel like your life in jeopardy or somebody else's life is in jeopardy. So let's talk a little bit about PTSD risk factors. And we can think of them as sociodemographic risk factors, behavioral health factors, other kinds of pre-trauma factors, or factors that surround the traumatic event, peri-trauma factors. Let's start with sociodemographic. We already heard female risk, younger age, but things that make people vulnerable, or feel challenged in their lives can increase the risk for PTSD. So, for example, getting divorced, having low income, coming from a marginalized group, whether that be by race or by gender identity or sexual preference. Let's talk about behavioral health factors. So, if you're diagnosed with a mental illness, that increases your vulnerability to PTSD. Having a substance use disorder, having alcohol use, having a family history of a psychiatric disorder, all of these factors can contribute to the vulnerability to PTSD. Life history factors such as a history of physical disease, adverse childhood events, or generational trauma. In other words, having a parent, for example, with PTSD can increase your vulnerability. And then factors that happen around the time of the trauma, such as cumulative exposure to potentially trauma experiences or experiencing a particularly brutal kind of trauma. So let's talk a little bit now about some of the risk factors that increase the likelihood of developing PTSD. But let's also not forget those resilience factors that help to reduce the likelihood of developing PTSD. And a little bit what we're trying to get at is that when you have a group of people and they're exposed to the same event, only some people will develop PTSD or PTSD symptoms, whereas others will be relatively more resilient. So some of the risk factors include being exposed to previous trauma experiences, getting hurt, being physically injured in the context of the trauma, or seeing other people hurt and killed, feeling a terrible, overwhelming horror, or in the face of feeling helpless, um, having little or no social support after the event, or having to deal with other negative consequences of a terrible traumatic event, which may be grieving the loss of other people, losing your home in the case of a flood, or other kinds of life experiences. Resilience factors are sort of the opposite, being connected to support systems, getting support from other people, friends and family, coming to terms with the experience, making sense of it, having coping strategies to deal with the symptoms that arise after a traumatic event, um, and being prepared for the events despite experiencing fear at the time of the trauma. Now, an area that I have been very interested in is what about genetics? Well, how does that contribute? So we know that about 40%, 30 to 40% of the vulnerability to developing PTSD comes from some heritable component, including molecular genetic risk factors. And we finally, within the last few years, have large scale genetic studies, in particular from the Million Veteran Program, which is now characterized several 100,000 people. And these genome-wide association studies, or GWAS, have identified a number of risk mechanisms through which the genetics of PTSD might be expressed. Some of these risk genes seem to be related to stress response, such as corticotropin releasing hormone receptor 1 and an opiate receptor signaling gene, neuroplasticity modifiers in the brain, factors that govern the integrity of neurotransmission, cell division, or cell adhesion. What's interesting is many of these genes are also present in abnormally regulated in postmortem brain tissue. In addition to the genes identified from the GWAS, genes involved in stress and inflammation in the brain, such as FKBP5, and genes involved in inhibitory neurotransmission, you might say the brain's resilience system, also seem to be implicated in the postmortem studies. In other words, the GABA neurons. So we're beginning from genetics research and from the postmortem analysis of brain tissues, beginning to get some ideas about the themes that through which the vulnerability in the biology of PTSD are expressed. Let's shift gears now and talk about the symptoms, the common symptoms of PTSD. And as you can see, the clusters have the symptom clusters are called B, C, D, and E. And that's because the A criteria is the presence of a trauma itself. One cluster of symptoms are called intrusion symptoms because these are experiences that intrude upon your life and keep bringing the memory of the trauma back into your consciousness. This can happen while you're awake in the form of intrusive and distressing trauma-related thoughts. They can occur when you're asleep, such as trauma nightmares, recurrent repetitive nightmares that people have. And they can occur in a kind of quasi trance state that we call flashbacks or dissociative symptoms, where reminders of the trauma may be relived as if the movie is replaying all over again. Criterion C are the avoidance symptoms of PTSD, where people actively try to avoid thoughts and feelings associated with the trauma. In order to do that, they may be avoiding situations, people, and places that trigger those memories. Negative moods include loss of interest in activities, feeling disconnected, numb, detached from other people. But they may also be associated with thoughts, negative beliefs about oneself or others or the world. And there may also be difficulty recalling the actual trauma, some forms of memory impairment, a cognitive aspect of PTSD. The part of the PTSD that often gets the most attention are the hyperarousal parts, the difficulty sleeping, irritable, angry outbursts, difficulty concentrating, increased startle, being on edge, being in this kind of defensive mode where you hyperreact to experiences that you experience as threatening or unsafe, make you feel vulnerable, but other people might not respond very strongly to. So let's map these clusters of symptoms onto the diagnosis of PTSD in DSM-5. As we were saying before, cluster A is the presence of the trauma itself. Cluster B are the re-experiencing symptoms we just reviewed. Cluster C are the persistent avoidant symptoms that we just reviewed. Cluster D are the negative changes in mood and cognition. And for the diagnosis of PTSD, you have to have at least 2 of these symptoms. And then lastly, cluster E are the arousal and reactivity symptoms. And there you again need at least 2 symptoms. So you can see 1 re-experiencing, 1 avoidance, 2 negative cognition and mood, 2 arousal or reactivity symptoms. If you have meet those criteria and have symptoms for a month, and if those symptoms cause distress and perhaps functional impairment, and if those symptoms are not attributable to another medical condition, say panic disorder or some other condition, then you meet the diagnostic criteria for PTSD. And one of the big problems with PTSD is that people are often unsure of whether or not they have PTSD. They may not recognize it in themselves. They may not see that they're experiencing PTSD related symptoms, or they may see and understand it, but they may not seek help. They may not either wish to seek help because of being ashamed about their illness, or they may not know how to seek help. In other words, where to find the kind of help that they need for their PTSD symptoms. So when you look in large studies, the time from the index trauma to the getting help can range over a decade and even longer. And the duration of illness in clinical trials as a result are commonly over a decade. So one of the challenges that we face in dealing with PTSD is making sure that people can get the help they need. As we were just saying, some of the barriers here are uh, complications of the diagnostic criteria themselves, the very highly heterogeneous nature of PTSD symptoms that can make it hard for people to recognize that they have PTSD, and as well as the stigma that prevents them from getting help. One of the problems, of course, is that people with PTSD are often misdiagnosed because they may present with depression. They may get treated with depression instead of PTSD, or they present with anxiety. They may get treated with generalized anxiety or panic disorder instead of PTSD. It's really important to recognize the presence of the trauma and link it to the diagnosis in order to make a good diagnosis of PTSD. PTSD also has significant economic costs. My colleague Lori Davis at the University of Alabama has suggested that the overall cost of PTSD for VA is almost $43 billion. And in the civilian population, almost $190 billion. Now, these costs come from various sources: direct healthcare costs, non-healthcare medical costs, or non-healthcare costs, um, the burden of unemployment, productivity loss, costs due to caregiving, and shortened life expectancy. You can think of the burden of PTSD as a pyramid, and 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 where one kind of problem builds on another. I sometimes think of it as an onion. You know, some people are born in families that have experienced generational trauma, and they're vulnerable then from their early childhood on. Then they may experience adverse social environment in their childhood, and childhood trauma, physical abuse, sexual abuse, neglect, that compounds the impact of their family vulnerability. Adverse neurodevelopmental exposures, social isolation, health risky behaviors like drug abuse and things like that. And so the impact of trauma can be compounded across several factors, several layers of factors that compromise personal, emotional, and physical resilience and increase the vulnerability to disability, severe symptoms and distress, and ultimately perhaps even shortened life expectancy due to the worsening of medical illnesses by a life filled with stress, not to mention suicide risk. Now, if you look overall in populations of PTSD, you see that women have a 6.7 elevated risk chance odds ratio of suicide, men almost a fourfold increase in risk. And some of this is related to the complex medical and psychiatric comorbidities. If you control for the psychiatric disorders, you still see a residual impact of PTSD, with women having almost a 2.6 fold increased risk for suicide, and men about a 1.7. Okay, so let's talk about a patient, which hopefully will be a platform for some discussion. 48-year-old man presents to his primary care provider for his annual checkup. He says, "I'm here for a tune-up." And he filled out forms uh, that are very helpful, that measure depression, that's the PHQ-9, anxiety, that's the GAD-7, and in this particular for this particular patient, he actually filled out a PTSD symptom score, and where called the PTSD checklist, where he's had a score of 35. So so unlike the typical clinical setting where a person presents and says, I don't feel well, I feel down or discouraged or hopeless," this by collecting these self-rated, easy to complete questionnaires, the doctor has gotten information that's very useful, that says this patient has some depression symptoms and some significant anxiety symptoms and PTSD symptoms, which would really tip the hand of the clinician, if they're attuned to it, to recognize that their patient has significant PTSD symptoms. The patient, in this case, checked the electronic health record, notes that he was seen in the emergency room 4 months prior for minor cuts and bruises from a motor vehicle accident. Okay, so there's criterion A, a potential event which could have caused PTSD symptoms. The patient says he's been on edge, arousal symptoms, irritability, other things. He doesn't feel engaged, and avoids game nights and retires early. So some avoidance symptoms, some cognition symptoms, some negative mood and thought symptoms. And he's been having thoughts about the motor vehicle accident. In other words, re-experiencing symptoms. Upon direct questioning, he states that he has received only minor injuries in a vehicle pileup, but he witnessed two others. So he had risk factors for developing his PTSD. So you can see how the diagnosis of PTSD can unfold very easily once you pull the thread of the story of their trauma exposure, or work back from the symptoms that are reported to the trauma history. In conclusion, we've reviewed a number of risk factors for PTSD that occur at many levels. We've talked about the symptom clusters of PTSD and how they manifest and contribute to the overall profile of PTSD. We will follow this patient in part 2 of this webinar series, where we will then address some of the issues related to treatment. Let's talk about some of the questions that you have. Um, One question is, what's the best way to begin a discussion about PTSD? I usually don't hold back. They know what they've experienced. I know I'm not going to make it worse by just asking about it. And so I will say, has something happened that had that keeps coming back in your life, that you find yourself very preoccupied about, something terrible in particular? I am sensitive, though, as people may respond very strongly to starting to talk about it. Talking about it can trigger a lot of distress, and so I'm mindful of that and tread very gently in obtaining the trauma history. Um, Another question is, what is the neurophysiology of PTSD? And I would say this is a very complicated story. But some of the themes that we noted in the biology of PTSD, the the tendency to have a deficit in GABA and therefore to have overactivity of anxiety, or the tendency to affect the neuroimmune system. These are aspects that are now turning out to be important. Um, what do you think about trauma-induced psychosis, and particularly psychosis that can continue many years after the triggering event? You know, the boundary of PTSD and psychosis is an important one to consider. Because PTSD creates feelings in many people of vulnerability, defensiveness, shame, and difficulty managing arousal, people with PTSD can appear to be quite paranoid, even when they don't necessarily have a paranoid psychosis. However, some people with PTSD do, and particularly if their PTSD symptoms are in the severe range, can become psychotic, and they can have delusions, hallucinations, as you would see in other psychotic conditions. And those patients um, are generally treated with antipsychotic medication. Another thing to bear in mind is that just because you have schizophrenia doesn't mean that you can't also have PTSD. And there are groups of people with schizophrenia who in their lives have bad traumatic experiences. Some of these people may have been assaulted, for example, if they were homeless, and had other terrible life experiences prior to developing schizophrenia that led them to have PTSD. In those patients, you have to make sure you're treating the schizophrenia, often medication and support, and the PTSD in a very gentle and careful way. If 70% of the population experiences trauma, where do we draw the line between what is a healthy response to to the trauma and what is a pathological one? In other words, is there a spectrum of PTSD? And so the way that I think about it is, and this is maybe not orthodox, but when a person comes to you for help, the most important question is not, do they meet DSM-5 PTSD criteria, but what are they suffering from, and how can you be helpful? Um, I think of the diagnostic system as a framework that helps me to be better attuned to the experiences that a person is having. So it turns out that many people who do not meet the full spectrum of PTSD diagnostic criteria still have high levels of distress and may even have disability related to what's sometimes called subthreshold PTSD or PTSD. So what I'm really interested in as a treater, because a person is coming to me for help, is to help the patient understand what they're going through, um, which I can do if I get a careful clinical history, and then to um, them uh, help them manage their distress, regardless of where they stand on in terms of the severity of their PTSD. Now, the flip side of this story is a tendency that can happen sometimes to pathologize healthy people. In other words, a person who is fully engaged, enjoying their life, who has good social relationships, who has, able to work, um, is able to experience a full range of feeling, able to get pleasure. It is not impossible for them after a severe life event, technically, to meet the diagnostic criteria for PTSD. So I wouldn't assume that everybody who has been exposed to a terrible trauma, and even if they have symptoms that they have that are not intruding on their lives, but formally meet the diagnostic criteria, I wouldn't assume that they need my help. Although I would certainly inquire about that if that history was obtained. So we have this tendency to think about these um, diagnoses as labels or boxes that where everybody needs to fit exactly in the box. And what I'm saying is that clinical judgment comes first, and then the box um, is a guide, is a help, is a tool that we can use to both better understand our patients and to be more responsive to what they're needing. So it's wonderful to have the opportunity to talk to you about PTSD, and I look forward to continuing this discussion.